So first of all, we'll talk about localized dMMR stage 3 colon cancer patients. Atomic data has been presented this year, which has changed the standard of care for this group of patients. Now, most importantly, localized dMMR colon cancers are not rare. They constitute about 15% of the all localized colorectal cancer patients. Importantly, they are resistant to 5-FU or capecitabine, and they have relative resistance to even oxaliplatin-based chemotherapy regimens, as we have seen in Keynote 177 and the Foxtrot study results. Also, I want to remind you that as of now, our standard of care was oxaliplatin-based adjuvant chemotherapy for the resected stage 3 dMMR colon cancer patients, but that was based on a retrospective study called AGEO study. There was no prospective data as of now until this atomic data has been presented recently. So this is the atomic trial design, very straightforward, clear design, where resected stage 3 dMMR colon cancer patients were enrolled and they were randomized to two arms within 10 weeks post-surgery. The standard arm received FOLFOX 6 times 12 cycles, and the experimental arm received FOLFOX for 6 months and then atezolizumab for 1 year. Primary endpoint was disease-free survival. So this is the survival curve. The 3-year disease-free survival was about absolute 10% superior than the standard arm, 76% versus 86%. Very strong p-value, very strong hazard ratio of 0.50. So importantly, the absolute improvement in the 3-year DFS is about 10%, which is quite remarkable. And as far as safety is concerned, there were a lot of grade 3 and 4 side effects because all these patients received chemotherapy as well, which was about 72.3%. And importantly, 2 patients died from treatment-related complications. So I think atomic data has established immunochemotherapy as the standard adjuvant therapy for this group of patients. However, the NICE study, which is a competing approach in which immunotherapy is given in the neoadjuvant fashion, that is another competing approach which needs to be mentioned. In the NICE study, about 115 patients were enrolled, and these patients were treatment naive, and clinically they were stage 2 or stage 3 colon cancer. All patients had dMMR tumor. A large number of patients had T4 tumors. That's something to remember. These patients received only 1 month therapy, 1 dose of ipilimumab and 2 doses of nivolumab, and they underwent surgery. And the waterfall curve is quite impressive. 68% of these patients achieved PCR. About 95% of patients achieved major pathological response. Surgery was delayed only in 2 patients. And their last reported 3-year disease-free survival in 37 patients who completed 3 years of surveillance was 100%, which is quite remarkable. So now if we put these 2 competing approaches side by side, atomic approach versus niche approach, we can see that atomic study was a phase 3 study with about 700 patients, but niche was a single arm study with 111 patients. The patient population were similar. The intervention was remarkably different. 1 year in atomic study versus 1 month in niche study. Importantly, the 3-year DFS in the niche study was quite impressive, which was 100%. The grade 3 and 4 side effects were much higher in the atomic study, 72% versus 4%. There were no treatment-related death in the niche study population. So I guess the questions which remain after the presentation of atomic data are these. We know that surgery cures 50% of stage 3 patients. Then what's the absolute benefit from 1-year-long immunochemotherapy in this population? Also, do the ctDNA negative patients derive any benefit? Um, we also know that low-risk patients um, are at much lesser risk of cancer relapse, um, and typically they get 3 months of chemotherapy. Do they really need 6 months long FOLFOX? And lastly, do we need a prospective randomized study to compare the atomic approach versus niche approach? However, all said and done, at the end of the day, based on the atomic study, I think we have a new standard of care, which is adjuvant therapy with FOLFOX for 6 months and atezolizumab for 12 months for resected stage 3 dMMR colon cancer patients.